An exciting topic. We have never introduced this topic before about how to incentivize living kidney transplant. The speaker is Dr. Nasr Ghahramani. He was my mentor actually during not only my nephrology fellowship but also through my Master of Public Health. He's the Chief of Nephrology at Penn State and the Acting Chair of Medicine. Dr. Ghahramani, thanks for coming.
Good afternoon, and thank you so much, Dr. Ahmed, for organizing this symposium, for the invitation. It's an honor to be among thought leaders and experts in the field. Okay. So, although I don't have any financial disclosures, I do have a couple of non-financial disclosures. My own thinking about this whole incentivized donation has evolved over time. So in 2010, I debated with Dr. Danovich at the ATC regarding incentivizing donors. And at the time, I was pro. In 2014, 4 years later and a few miles north at the World Transplant Conference in San Francisco, I had realized that the model that I was talking about had significantly changed. And maybe my views had changed also, because we are allowed to change our views when we see that the data is actually not what it should be. Or it does not prove what intended to prove. So as some of you might be aware, the only model for an incentivized donation that's run by governments and that is actually regulated, and here I have regulated in quotes because it did start out as being regulated, but then it ended up not being as regulated as it was intended to be. Now, this talk will probably, nothing in this talk is going to appear on any board exam, so just sit back, relax, and think about how we can at least remove the disincentives to donation. Forget about the incentives. Think about how we can remove the disincentives to donation. And to sort of get to that point, I'm going to present some information and some data from the Iranian model and also elsewhere. So you can't really talk about incentivized living donation without talking about ethics. But if we were to talk about the ethics of incentivized donation or reimbursements, etc., it would take hours and hours and days, and that's not the intent of this talk. So these are the four main principles, ethical principles that come up when people talk about incentivizing donation. Now that that's out of the way, I'll give you a little background about the Iranian model. And I practiced in Iran. I actually helped set up a transplant program in Shiraz, in my hometown. I practiced there for about 10 years, so I've seen the evolution of the model and the huge benefits that the model had. The first kidney transplant in Iran was performed before the revolution, many years before the revolution, in 1967 in Shiraz. And then there were very few transplants after that because the surgeon who did the transplant in Shiraz moved to Tehran, and Tehran did not have an interest in doing transplants, so most of the transplants were through Eurotransplant between 1967 and 1988. So in 1988, and this is after the revolution, there were a large number of patients who required transplant. There was no deceased donor transplant infrastructure, and patients were being sent mainly to the UK with their own donors to receive a transplant there. And it became very, very expensive for the government. And remember, this is the time of post-revolutionary war between Iran and Iraq, the 8-year war, the devastating war, and many sanctions imposed by the West on Iran. So everything was expensive. Dialysis was very expensive. Transplant was essentially not an option. So a group of physicians gathered and came up with this model. In 1988, they adopted a regulated, government-funded living unrelated donor transplant program in which the government essentially paid the donors to donate to a recipient. And this was through the equivalent of the National Kidney Foundation, an advocacy foundation, where the donors and recipients met, and there was, at least theoretically, no handing of money from the recipient to the donor. So it was a very unique model, developed out of need and innovative. It led to many, many transplants, tens of thousands, close to actually hundreds of thousands now, of transplants being done through this model of living unrelated donor transplant that was incentivized. More recent studies have shown that it wasn't really an unbiased and impartial system. It's not. It's definitely not now an unbiased and an impartial system. It does favor the wealthy and the more educated. And the market actually allows that because the fixed amount that the government pays the donor is about the same as it was initially, and the inflation is skyrocketing. So the market essentially allows the donor to receive money from the recipient outside what's allowed by the government. Other shortcomings are that there's very poor donor follow-up. So we don't really know what happens to the tens of thousands of donors who donate, and then they leave, they go back to their towns, and there's really very little donor follow-up. So in one study, 500 donors were invited for checkup, and only 6 responded. There have been several studies looking at the quality of life of the donors, comparing them with the general population and comparing them with the living related donors, significantly lower quality of life for the paid donors. So since quite a while, I've had an interest in looking at how has this process of no questions asked paid living donation impacted the deceased donor transplant program, the multi-organ deceased donor program, the non-renal deceased donor program, or the infrastructure for deceased donor programs. When you look at the data, deceased donation has increased over time, but has significantly occurred at one center, and that's the center in Shiraz. That's the center I was talking about, my hometown, where we decided very early on, in about 1999, 2000, that we would not accept living unrelated donation through the paid program. Anyone who did not have a living related donor would have to be on the waiting list for a deceased donor kidney, and then they would be allowed to go out into the quote-unquote market. That did not happen, meaning that everyone essentially received the kidney within the 6-month period. And that allowed formation of the infrastructure in Shiraz that's very, very unique in Iran. I had mentioned earlier that the first kidney transplant was performed in 1967 in Shiraz. The first liver transplant in Iran was performed in Shiraz, and the first pancreas transplant was performed in Shiraz. And that's mainly thanks to the fact that paid living kidney donation was not allowed. So the hospital that you see here opened up in 2017, and it's dedicated to transplant. The number of transplants that are done per year there, liver, any guesses? 800 per year. Kidneys, 1,200 per year. And it's essentially the only center that does other types of transplants, such as intestine transplant, pancreas transplants, and does most of the liver transplants. This is the graph essentially showing the trend. So the red is deceased donor transplant in Shiraz. The blue is living unrelated donor transplant, and over time that has gone down and essentially has become non-existent, while the deceased donor transplant has increased. So Shiraz focused on improving the deceased donor transplant infrastructure and has been essentially relying on deceased donor transplant exclusively. Now, you might ask, living-related donor transplant. Unfortunately, when you have paid living unrelated donor transplant, many of the living-related donor transplants tend to become paid living-related donor transplant. We don't have data on that, but there are many anecdotes that my colleagues have shared with me. Nationally, Shiraz has been driving the liver transplant program. So the red here is all of Iran, and the blue is Shiraz. So as you see, most of the liver transplants are done in Shiraz, 4 times more liver transplants than the entire country combined. So significant difference, and this is one center, one hospital, one center compared with the entire country. This is essentially the same information in tabular format, the number of liver transplants that are done in Shiraz versus the rest of the country. And this is how the center, Shiraz, has focused on deceased donor transplants and has been able to increase through marketing and education of the public to increase the per million population donation rate. So Shiraz has a rate of 20, while Tehran, which has many, many more centers for transplant and is more populated area, has 14.8. There have been some studies, I'm sure you're all familiar with this, that does financial compensation for living donation change willingness to donate? In the US, seems like it does not. But looking at over 100 countries, Sadiq and colleagues identified 23 that had reimbursement programs that shifted the burden of non-medical costs away from the donor. In other words, removing the disincentives, and in contrast to the US, it seems like removal of disincentives has a positive impact on the country's living donation rate. This is a modeling of the various disincentives to donation and how much each one would cost, and it seems like if we were to remove disincentives to kidney donation, the cost would be about $37,000, and it would add to 12,500 additional living donors. So can we extrapolate from the Iranian model? I would say no, we can't extrapolate. That was a model that was built because of a need, very certain situation, a completely unique situation, a unique set of circumstances. So it worked there, but it's really questionable if we can extrapolate from that. And the reason that I'm bringing this up is that it has been proposed that that model has been successful because so many transplants have been done, but that was a different era. Even now, it's not the answer for Iran's transplant program. So in summary, the model, the pro part is that the model was great. Many people received kidneys and they survived. They're not on dialysis. It saved a lot of money. But at the same time, it probably hindered the deceased donor transplant program nationally. And by doing that, it impacted the lives of those who needed liver and needed other organs, heart, etc. Some concerns are that the model does tolerate side payments. The prices fluctuate based on the bargaining skills and abilities of the donors and the recipients to bargain. And it's really not regulated. It's at least at this point, it is transactions that are unregulated. There are poor donor follow-up, unfavorable quality of life, and this incentivizes the development of the deceased donor organ transplant programs. So maybe an alternative to consider is how to remove disincentives and to reimburse the costs, whether they're evident costs or hidden costs that the donors have to incur to improve living donation. So with that, I thank you and open to questions.
Any comments, questions? So I have a comment. So would you support here in the US there will be an incentivized money from the government for living donors? Would you support that sort of that practice?
I don't think so. I think removing the disincentives is the key. The donor should not bear all the costs, taking time off, traveling, etc. I know that there's some minimal, but some minimal compensation, but that really doesn't answer the question of are the donors, do we expect the donors to bear all the burden? And it's different, right? The way we think about things here is different. I've struggled with this, and as I mentioned, I've swayed from the pro to the con in a 4-year time period. I don't really have a very good answer to that. I know that it's an open debate.
I just want to say I agree with you in terms of removing disincentives more than taking those.
Yeah.
Personally, not in favor of those trials.
Yeah.
How about paying for health insurance?
That I would, I think donors should be supported in every way, including paying for the health care.
Like to be provided with the free health insurance for the rest of life?
Extend Medicare,
for
Yeah.
extend Medicare to the donor, maybe even for a period of time.
Yeah. Please.
Yeah, there is a data from the UK that altruistic donation donor actually protective from mental illness. They have the data about that.
The way I present this usually to our colleagues is it seems like everyone celebrates. It's a birthday party when someone gets a kidney from a living donor, and the donor is not invited to the party. So everyone else benefits, right? We benefit as physicians. The hospital system benefits, the government benefits, the recipient benefits, the recipient's family benefits. The living donor doesn't really receive any benefits. Now, receiving benefits is one thing, but I don't think there's anything wrong with, for example, extending Medicare or making sure that they don't lose their job because they're taking time off. The simple things like that.
Thank you so much.
Thank you.